All right, welcome everyone to Grand Rounds. It's another beautiful day in November, and just want to remind everyone that on December 1st it is World AIDS Day. And so in honor of that, our Grand Rounds this week and next week are talking to us about HIV and different topics related to that. And so this morning I'm very honored, and all of you know about my issues with pronunciation, to present Dr. David Malebranche, who is MD, PhD, Associate Professor from Morehouse School of Medicine. And his talk today is Do We Need a Hell's Kitchen? Medical Contexts in the HIV Treatment Cascade. So I want to say, I'm going to talk to you a little bit about his CV, and his CV is simply amazing, and he has been highly awarded and honored. He did his medical school at Emory University. This was followed by his residency with a emphasis in primary care at New York University Hospital at the Cornell Medical School campus. He did his second residency at the New York Department of Health in preventative medicine after that, during which time he also did his MPH at Columbia University. He then was a visiting assistant research scientist at the Center for AIDS Prevention Studies at the Department of Medicine at UCSF, and he did that from 2002 to 2004. He returned to the East Coast after that. He has been on faculty at Emory University. He has been a primary care physician at University Health Services and University of Pennsylvania in Pennsylvania, as well as a primary care physician at Cobb County Adult Detention Center in Marietta, Georgia. Most recently, he has joined the faculty at Morehouse School of Medicine. He has 45 published papers in the area of HIV, 6 book chapters, 39 presentations that are invited presentations, and he has been well funded, including an R1 and an R21. His work really centers around HIV and specifically in black gay men, and he has received numerous honors throughout the country. I picked out 3 that I thought were interesting and talk about the breadth of his knowledge and talent. In 2012, Emory University medical students and fellows honored him with the AOA Honor Medical Society Award. That's a very coveted thing. In 2012, he received the American Journal of Public Health Paper of the Year. And that paper was titled Exploring the Bisexual Bridge, a Qualitative Study of Same-Sex Disclosure and Risk Behavior Among Black Bisexual Men. And finally, in 2016, although I just heard he's flying out to LA to receive another national award tonight, he got the Red Door Foundation Flamethrowers Honoree, which was given to individuals who have trailblazed in black LGBTQ communities. And when I asked him what is he most proud of in his career, right now it's work he's doing with a local organization called the Counter Narrative Project, which I think speaks to his work with the community. And so with that, Dr. Malebranche, please come up.
Thank you so much. Good morning, everybody. So thank you for that wonderful introduction. I do want to say a few thank yous. And I'm originally from upstate New York, so this weather doesn't bother me. But I chose to move to Atlanta because it's just warmer. I want to thank Dr. Sosman for inviting me here and all of the staff that have worked with me so far, Chris Chapman, Marge, Michael, Gretchen, who I owe a great deal of apology to. If you guys go online for this CME, she asked me a very simple thing, was to do 5 questions. And I guess it was written in the instructions to not include a true and false, so what did I do? I included a true and false, and she sent me an email a couple of days ago like, hey, could you change that true and false to a multiple choice? And of course I just didn't have the time, and so I didn't do it. So I apologize to Gretchen. So if anyone says something to Gretchen about it, it's absolutely my fault. She actually told me, so I don't want her to get thrown under the bus for that. Dr. Sosman was amazing yesterday. He was protecting my HIPAA. I was in the shower yesterday, and I turned 50 in February, and I was taking a shower yesterday morning before doing some of the activities, and I slipped and fell on my rib, and I hit the side of the bathtub. It's not funny now, and when I laugh it hurts, but we kind of made it through the day, and then I went to an urgent care center, and Chris Chapman was nice enough to take me there. It turns out I had a rib fracture. And so, of course, I'm a Generation X person, but I had a millennial moment where I said, oh, I have to post this on social media. So I posted it on Facebook, and of course, the jokes started coming, like, oh, do you need a life alert? Oh, this is 50, David. And then the best one today, when they knew I was doing a grand rounds, a good friend of mine said, you know, you're really going to do well. Go out and break a rib. And I said, these are my colleagues and my friends. So the talk I'm going to do today is, do we need a Hell's Kitchen, medical context in the HIV treatment cascade? I needed to go over some disclosures, first of all. I do speak for Gilead Science on their PrEP Speakers Bureau. I don't do treatment for HIV speaking bureaus, but I just do PrEP. And also I'm an advisory board member when they have some questions, particularly when it comes to Black and Latinx communities. So for my agenda today, I'm going to talk a little bit about the HIV epidemiology. It's kind of a requirement in these talks that we have to give you some charts and graphs and numbers. I'm going to talk a little bit about the treatment cascade and health inequities, discussing the medical context and exactly what I mean by that, and then looking inward at medical systems. And this is why I'm really going to talk about what we do as far as researchers and medical personnel when we see that there's a problem in the community or there's a problem with an outcome, medical outcome, and how we don't really look inward as much as we should. Then hopefully leave some time for summary and questions. So, do you all know this guy, right? So, Gordon Ramsay from Hell's Kitchen. I heard, I was actually making an analogy, and I'll bring it to you later, but a lot of people were like, what is this Hell's Kitchen about? I'll explain it later, but it turns out I used the wrong TV show, and I actually should have been talking about kitchen nightmares. I can't keep up, because Gordon Ramsay is he's kind of a nightmare in and of itself. So diagnosis of HIV infections among adults and adolescents by transmission category, and this is nationally and throughout 2017, so I was happy I had some of the updated data. But you can see that still about 2/3 of the cases are among men who have sex with men, with a little less than 20%. So we're seeing rates going down among heterosexual women, and then heterosexual males and some of the other rates, IV drug users. But I think given what's going on with the opioid epidemic nationally, we're probably going to see some of these IVDU numbers going up in the future. And then also, if you look nationally at the diagnosis of HIV infection among adults and adolescents by transmission category, you can see male-to-male sexual contact among the men is about 82%, and among women, heterosexual contact is 86%. This is actually a graph from the CDC that talks about what's going on in the South. And I'll show a couple of graphs later that really show how the epicenter of HIV is in the southeast United States. It's not New York and San Francisco the way it used to be. But you can see 32% of the new diagnoses were among men who have sex with men. We have an increasing rate of new diagnoses among Hispanic or Latin MSM. And then Black MSM living with diagnosed HIV, 59% within the South. And then if you look at the bottom here, Black women accounted for 71% of women living with diagnosed HIV. So again, the reason why I'm showing you this is to show you that the Southeast is really that area that's getting hit the hardest by HIV right now. I look at HIV as an opportunist. So you put HIV in circumstances where there are social discriminants, there's oppression, there's different kinds of problems socially that are going on, determinants there, and it's just going to flourish. So I bring us all the way back. I could start here with poor and uninsured Americans and where they tend to live, and you can also see how it's kind of in the Southeast. But I also like to bring people back to the spread of U.S. slavery from 1790 to 1860, and you can see it's also in the Deep South as well. So when people want to say, like, slavery's over, and, you know, why don't people get over it? The ramifications of what's happening in slavery, if we look at health disparities, poverty, poor outcomes, and racial inequities that we see, we can't say that this is a coincidence. We can't say this is just a coincidence that this leads to things like this. Because if you were to put other diseases as well, you would see that same kind of trend. And then also what's interesting is looking at Medicaid expansion in the United States. And you can see here in the Southeast, the yellow color for the states here are not adopting at this time. So these states chose not to expand Medicare when the Affordable Care Act came available. What this does in the context of HIV, it makes it a little bit more difficult to pay for people's services, certain numbers of services when they're uninsured or have or no insurance at all. And I was actually surprised because I didn't know that Wisconsin was one of the states that didn't do Medicaid expansion as well. I've actually heard that like a few times, like that's about to change, so don't dog us because of that. So we can see that things are going to change a little bit about that. So let's take a closer look on Wisconsin and where we're at right now. So HIV diagnosis rates across the United States, you can see the U.S. average is about 12.3 per 12.3 cases per 100,000 population. You see Wisconsin is down here at about 4. Georgia is about 20. This is from 2015, but actually Georgia has leaped up to over 30. I think it's like 31 right now. So Georgia is actually one of the states with the highest rates of HIV infection right now. And then if you look at sex and race ethnicity stats in Wisconsin, this is from 2012 to 2016, you can see the racial disparity again among men, among women, black women as well. So again, this racial disparity, what's going on in Wisconsin mirrors what we're seeing nationally. And then young men by race and ethnicity, this is between the ages of 13 to 29. You can see the year of diagnosis, and the rates were already higher, but then they kind of go up and go down, and right now they're on an upturn. And this is among black men who have sex with men who are younger, 13 to 29 again. So you see this kind of pattern coming up. And then the estimated transmission category, again, just saying here, it really hasn't changed. I think back in the day we used to try to make sure that people weren't doing things like saying, oh, it's a risk category because of who you are. And people will say stuff like, it's not a gay disease. And while it's true it's not a gay disease, you can't ignore the fact that it is squarely set among men who have sex with men and gay men. So there's an acknowledgement that it's not because of who you are that causes your risk of HIV, but it is more common in MSM populations. And then with the geography, we're looking at Milwaukee has the highest number of doses, or cases, I'm sorry. And this is, I think, 115 per 100,000. And then here, we're in Dane County, correct? So this is the one here, so this is the second highest. And I've seen a bunch of different charts that say that, but it seems like Milwaukee has the highest numbers that we've seen. It sounds like over time that's been kind of the history. What I do want to also bring people's attention to who are new to the HIV field is that this isn't a new thing in Wisconsin, and back in, I think this was 2008 or 9 that this was published, but they looked at an increase in newly diagnosed HIV infections among young black MSM from 99 to 2008, and they saw during that period, and the age group was between 15 and 29, that there was a 144% increase among this population during that time, and so this was a decade ago. And so things really haven't changed from then until now. And even when we look at the advent of all the wonderful science we have, all the PrEP, all the single tablet regimens, everything that we have, we're still seeing this racial disparity there. Which brings us to treatment as prevention and the treatment cascade. Is everyone familiar with treatment as prevention and what that means? Or some people, anyone who isn't really familiar with it? Okay, so there may be some people. Treatment as prevention is just the concept that anyone living with HIV, if they are HIV positive and they get on their medications and they get what we call an undetectable viral load, and so their viral load is less than 20 copies, their transmission risk to their HIV negative partner, if they're in a partnership with someone who's negative, is 0. And so not 1%, not 2%, but 0. And when I show you this slide, it's kind of looking at the science over time. Maybe about 6 or 7 years ago, HPTN 052 study came out, and they found that with heterosexual couples, one infection who got early antiretroviral treatment and 27 who got delayed antiretroviral treatment, there was a 96% reduction in the couples where the HIV positive partner was started on antiretroviral treatment immediately. And so that was reassuring then because it was a 96% reduction. What you look at, two of the main studies we've seen recently, partner study and then the opposites attract study. One, partners had heterosexual couples and men who have sex with men, and then opposites attract were men who have sex with men. Both of them found no transmissions within couples. Again, a serodifferent or serodiscordant couple where one partner's positive, one partner's negative. If the positive partner is on antiretroviral therapy and undetectable, there were no transmissions of HIV to their negative partners, 0. And what they did find, though, there were transmissions that weren't phylogenetically similar. So someone, the HIV negative partner, may have dipped out and got HIV, but the type of HIV wasn't the same as their partner. But what we're saying with this is, and it's brought together a whole thing about U equals U. It's a slogan that we use called undetectable equals untransmittable. And it's kind of empowering for people to know that folks who are living with HIV had trouble disclosing, thought that maybe they were stigmatized, felt stigmatized by partners, can now say to their partners, hey, if I'm on my medication, I'm taking care of myself, my risk to you is 0 based on these studies. And so that's very encouraging for a lot of people. The International AIDS Conference was held in Amsterdam this past year, and I told you about the partner study a second ago. They did actually a second arm called Partners 2. And what you'll see, this is Partners 1, and you can see the couples. There were 1,100 couples, 548 were heterosexual, 340 were gay. The number of condomless sex acts per year were reported to be 37 between these couples. and total condomless sex acts were 58,000. Rate of within couple HIV transmission, again, 0. Unlinked, what I talked about before, that weren't related to the couples, was 11. And with the Partners 2 study, what they did was they just really focused on the MSM folks, carried the MSM partners from the first study, and then added more MSM couples, followed them along from 2004 to 2018, and they found kind of similar things. And this was an increase in the number of condomless sex acts, almost 80,000 condomless sex acts in these couples. And again, the number here is 0 transmission when the HIV positive partner was undetectable. And that was actually defined as a viral load of less than 200, not 20, which is what we use today. And then there were 4 unlinked HIV transmission cases. Does that all make sense? So it's very compelling science, and it's interesting because sometimes the transition of science to kind of one-on-one communication, sexual partnerships, disclosure of HIV status becomes a little bit tricky. But for a lot of people, this has really helped out because now the science is backing folks up and saying, hey, you know, we're less of a risk than people think we are. And, you know, with this whole stigma of, you know, you're diseased, you can't have sex without a condom, you can't do this. For partners who do feel comfortable with that, and an HIV negative partner who does feel comfortable not using condoms with his partner, it does allow them that freedom to do that based on the science. And this brings us to the HIV care continuum, which, for those of you that are familiar with it or not familiar with it, it's a series of steps a person takes going from being diagnosed with HIV all the way to being virally suppressed. So they find out they're positive, they're linked to care, some kind of medical system, they're engaged in care, so they stay in over a certain period of time, they're prescribed antiretroviral therapy, and then finally they achieve viral suppression. And again, I presented to you the treatment as prevention statistics earlier because this is the goal right here. If you can get somebody to viral suppression, and you think about prevention of HIV, condoms are at the best are like 90-95% if used properly. Even PrEP is, in the studies from Gilead, are 90 to 92% if you take it every day. And so when you look at 100% or 0, treatment as prevention is going to be our best option for prevention in the future and for now. So when we look at stats from the CDC, and we're actually looking at all these different tenets of the HIV treatment cascade and where someone comes along with this, you see linkage to HIV medical care within 1 month after the HIV diagnosis. You can see with the states, the darker colors have a lower percentage. So in other words, people weren't getting linked to care as much in these darker colored states quickly, within 1 month after an HIV diagnosis. Why is that important? Because if someone doesn't get linked to care, they can't get on medication, their viral load will continue to reproduce, and they'll be at more risk of transmitting the virus. So you can see, and I know y'all are all like making a beeline to Wisconsin, right? Pretty much, yeah. So you're like, okay, we're pretty good, right? We're like 83%. So that's not too bad. You don't want to be in these darker areas. And you see again with the South, you see where a lot of the darker states are occupied. This is receipt of medical care among persons greater than 13 years of old diagnosed with HIV infection through 2015. And again at the bottom, receipt of HIV medical care defined as greater than 1 T-cell count or 1 viral load test in 2015. And again you see here some of the darker percentage where it's lower, 69%, 53%, is in the southern states. You do have a smattering of states here, but their HIV rates aren't that high where I think those numbers make a huge impact. This is what's more important here. And then Wisconsin actually is doing pretty well. As far as like 81% of those who are tested and linked to care actually get into care and are receiving medical services. And then this is actually talking about retention or engagement. So over the course of time, and how we define this is usually that someone receives a viral load or a CD4 count greater than 3 months apart. So that means they've been to see the doctor once, gotten a checkup, waited about 3 to 4 months, and then they come in again. And these are the rates that you see right here. Some of the lower rates are in darker colors, and then you see some of them trickle up in Virginia, West Virginia, some of these Midwestern states, and then Wisconsin is actually still doing pretty well. 62.6% of those who are linked and engaged in care actually stay there. And so you see that happening here, and then some of the darker states who aren't performing as well are again in the southeast. And then finally, when we look at viral suppression among persons, and this is again, this is the end of the treatment cascade. This is where you really want to be on the good side of this. You see the darker areas, the percentage 42% to 54%. That means that only like half the people that are engaged in care and on antiretroviral therapy are actually achieving viral suppression. Again, some of these darker states here, Wisconsin actually performing decently well compared to some of the other states. So again, we're seeing some of these geographic trends and what's happening not only in rates of HIV diagnosis, but once they get in medical care, that people aren't achieving viral suppression at the same rate in every state across this country. And then this is looking specifically at the HIV care continuum in Wisconsin through 2016. You can see again, living with HIV, diagnosed, linked to care, it goes down to 88%. So think of it this way. You have 100% here, 88% of 100%, you have 88 people here, 71% of 88 people. So it keeps going down lower and lower. So even if you have like 90% at each step of the HIV treatment cascade, you're actually not performing that well, because at the end of the day, if you get 90% of every part that are getting to those accolades, getting to those markers here, in care, retained, virally suppressed, you're only going to say about 71, 72 out of 100 will be fully virally suppressed. So you're still going to have 28, 29% who aren't virally suppressed that could transmit the virus. So 64% is a lowish number, and then this was put in there, and I was trying to figure this out, virally suppressed among those tested, but I also think it may be virally suppressed among those who are in care. So you don't take the whole patient population, but you actually funnel it down to like just the people that are really retained in care, and you do find that once people are staying in care, they do achieve viral suppression. So that's a good thing and something we can look forward to. So a lot of people look at this continuum of care and some of the drop-offs from each step, and they're saying like, well, what's happening and what can we do as a medical community in between these steps to make sure these patients that are coming in are getting to this end result of viral suppression? This is from the Treatment Action Group in 2013. They talk about bridges of diagnosis, and some of these numbers are old, but I want you to focus on what's happening in between the pillars. So intensify routine testing efforts, bridging to diagnosis. Implement and evaluate linkage case management. So sometimes we have social workers, case managers that make sure that patients are actually, when they get diagnosed, they are getting to clinic, they're getting to see a provider rapidly and getting linked to care quickly. And then bridging to care retention, using surveillance data better, medical records, outreach to engage people who have fallen out of care, those kind of things. And then finally, with the bridge to viral suppression, continue the retention services, prescribe ART based on the guidelines, all these kind of biomedical things that you can do. And we're thinking about some of the structural stuff, because as medical personnel in these clinics, we're actually struggling with a lot of the social determinants and social pressures that our patients are going under and trying to help them out so they can actually make it through this continuum to the end, because it's going to be vitally important. But sometimes we struggle. So what's happening in between those gaps? UNAIDS set a target for 2020, so it's in about a year or so, over a year. They want, again, 90% knowing, 90% linked to care, 90% viral suppressed when you're going down, or diagnosed on treatment and virally suppressed. Today's targets, and you look at the right side of this graph, leaves a prevention gap. So you see we get people diagnosed, on treatment, virally suppressed, but we have to do all these other things kind of in the meantime. And these are some of the biomedical technologies and innovations that we have at our disposal. Vaccines and cure, PrEP, combination prevention, microbicides, voluntary counseling, treatment as prevention, syringe exchange, harm reduction. And we have one here that kind of deals with the human aspect of it, which is human rights. So it's interesting to me when I saw this graph, I thought to myself, well, God, it's like all biomedical. And then the one thing about the human part is like one little small component of the puzzle. But to me, it's almost like the biggest part of the puzzle, but it's the one that we miss the most. And when we talk about the structural context, especially in the Southeast, there's always a laundry list of things that we can see that are influencing our patients and adversely affecting them getting to viral suppression. So it could be anything from religiosity and judgment, from your sexual orientation, from your HIV status, intersecting stigmas, so they all don't happen at once. So racism, sexual prejudice, sexism, gender identity discrimination, HIV stigma, etc. Poverty, federal and local policies, which could include HIV criminalization. And we see things like people getting thrown in jail for 20 to 30 years if they don't disclose their HIV status to their partners. Those things deter people from actually testing and getting their status, because they can always say, well, I didn't know my status, and then I won't go to jail. Whereas if you know your status but you don't disclose, you can be thrown in jail in a heartbeat. Being un- or underinsured, poor access of care, lack of Medicaid expansion that we talked about earlier, homelessness and food insecurity. These are all things that are driving the HIV epidemic, not only the rates, but how people navigate through the system and if they get to viral suppression at the end of the day. And it's a lot worse in the Southeast than it is in other areas of the country. A lot of my work and historically has been around black men who have sex with men. And some of the factors that I've seen positively and negatively influencing this from the literature include things like healthcare access, which could be everybody, insurance, income, housing disparities, obviously that's not just black MSM, positive ethnic and HIV identity formation. If someone has a positive identity formation of themselves, whatever identities they have, racial, ethnic, sexual identity, HIV, they're more likely to be in care and get to viral suppression. There were studies that show that people, black MSM compared to white MSM and other ethnicities, were actually just less likely to get HAART. And the research couldn't really explain why. They didn't do any qualitative follow-up, but they just seemed to be more likely to be prescribed ART. And then social capital. If you have friends, if you have your fingers in the community, if you're well integrated, that seems to work towards viral suppression as well. All this, when I look at it, I start to think to myself, well, what about the medical context? Because if you focus on the HIV treatment cascade, you'll notice that we're getting people tested, we find out they're positive, we get them linked to care. The bigger drop-off seems to happen once they get to us. So my original thought is kind of like, well, what is happening once they get to see our clinics? Why aren't they engaged and staying in care? Why aren't they getting to viral suppression? And more importantly, why isn't the research actually exploring that drop-off rather than focusing on HIV testing and linkage to care? So there's not a lot of studies that actually look at this. One of the studies that I found, which was conducted at the VA hospital in Atlanta, Georgia, was titled Retention in HIV Care Depends on Patients' Perceptions of the Clinical Experience. It was a qualitative study. They did 25 in-depth interviews. 92% of them were male, 68% were African American. And they stratified people into two categories. 16 were out of care, who had fallen out of care and weren't following up. And then 9 were in care. And I think they were using the same definitions where people had 2 more than 3-month follow-ups in the clinics or they didn't, to define those categories. The major findings for the facilitators who actually stayed in these HIV clinics were if the patients had patience with procedural issues. So they could put up with the bureaucratic BS that we put them through. If they were more patient with that, they were more likely to stay in care. If they had confidence in their clinicians, and if they had more interpersonal connections with staff, with the clinicians, so on and so forth, this seemed to be a facilitator to why people stayed in care. On the flip side, if you looked at the barriers, what they found was long wait times, having to wait in the waiting area for a long time to see a provider, low confidence in clinicians, and then customer service concerns. And the solutions, it was interesting with this study, and actually a colleague of mine is on this study, and I emailed him, and I presented this at a Emory CFAR conference not too long ago, at Center for AIDS Research Conference. And when he looked at these conclusions, and these were the conclusions from the paper, the solutions, they wanted system-level improvements. So they did stuff with the electronic health records. They made it easier for the patients to communicate electronically with the clinicians. They were doing other kind of structural things around that area. And then they also had a solution that they suggested doing cognitive attributions theory-based intervention for patients. Does anyone know what that means? Okay. What that essentially means is that we're going to help you to cope with our inadequacies so you can put up with us and stay with us better. Since patience is one of those facilitators, we're going to help you with this behavioral theory so you can deal with our crap. Does that make sense? Okay. Because sometimes you get caught up in all those words. I just have to make sure I break it down so I understand it. Like, break it down to me like I'm a 2-year-old. But what was curious here is that even though it said confidence in clinicians and interpersonal connections and customer service concerns, there weren't any solutions proposed around those. And what they told me, the authors told me, was that they were forced to kind of cut down, as we all know with writing papers, you're forced to cut out some of stuff, and so that stuff got left off for some reason. But to me, I felt like that was the most important part of this. Like, what are we doing? How can we instill more confidence? Are our clinicians not doing their job? Is customer service crappy? How can we improve the wait times? None of that was on the solution. So I thought that was an interesting finding. And then looking globally, I start to see that in other countries, other areas of the globe, people are talking about HIV stigma and other stigmas and how medical clinics may be underperforming when it comes to getting people to viral suppression. So in China, Latin America, and the Caribbean, there's a lot of HIV stigma, a lot of discrimination that's going on in healthcare facilities when someone living with HIV is simply trying to get care and stay healthy. There's fear of discrimination among men who have sex with men in Nigeria and Swaziland. So even if they don't have HIV, they're fearful of being discriminated against when they walk into a medical facility, so they don't even go in to get tested. So if they are HIV positive, they may not know. In Kenya, they did studies talking to clinicians, like, how comfortable do you feel talking about diverse sexualities with their patients? And a lot of the providers were saying, we don't really feel comfortable. We need more training in sexual health stuff. And so that's happening all over the globe. And then in the United States, discrimination against PLWHs, persons living with HIV, is happening in healthcare settings. And I'm going to focus, my next 2 slides will be on a magnifying glass, looking at provider-patient communication. It does appear to be playing a role. This was a study that was published back in 2013, and it was focusing on provider-patient communication. And the study took place in Portland, Baltimore, New York City, and Detroit. And it was called the ECHO study. It was an observational study. And what they did is they listened to audio recordings of routine outpatient HIV visits. And they used this theory called the Speech Act theory, which talks about language not only representing reality, but actually creating it. The participants were 34 physicians and 11 non-MD practitioners, 58% female, 66% white, 4% black, and 415 patients, 66% male, 59% black, and 78% reported being ARVs. And what they were looking at, these were patients where they were coming in talking about adherence issues with antiretroviral therapy. So they were recording the conversations and then doing analysis of the wording, the phrasing, and what was going on during those conversations in the exam rooms. What they found was that among the non-adherent patients, only 23% had any problem-solving dialogue with their providers. Number 2, significantly more directives and control parameter utterances during the antiretroviral problem-solving dialogue was happening. And then providers finally, and I thought this was very important, they asked fewer open-ended questions, fewer questions about patient opinions, and rarely checked for their understanding. Are any of those findings surprising? No, okay. So they continued and they decided to look, well, let's look at the racial comparisons between black patients and white patients. Use the same data, same recordings. What they found was that black patients made fewer utterances during those clinical visits than white patients. Providers showed more verbal dominance in conversations with blacks than whites. More dialogue related to adherence for black patients related to white patients. And finally, ARV dialogue with black patients were not more problem solving, but did include more provider directive utterances, meaning take your meds. Like not actually exploring into what may be the cause or the belief systems or what's happening that someone may not be able to take their medication. And what's interesting is that we did kind of a focus group yesterday, and Dr. Sosman was there, and they were giving us feedback about what was going on in Wisconsin at the HIV clinic and what's going on in the community and if there's a disconnect there. And we were talking about just general health, and they were saying, there was a woman in the focus group that was basically saying, you know, I come into a doctor's office and they just tell me what to do, and they're talking to me like giving me directives all the time, and I don't like that. And that was for hypertension, diabetes, whatever. It was kind of, you need to explore more who I am. You need to know more about me and not just tell me what I'm doing or what I'm not doing wrong. And they seem to also have a focus on the fact that the medical community always pathologizes black people. So it's always like, you're at high risk for this, you're going to do this, you're going to have this, hypertension, you're going to die of this, your leg's going to come off, you know, all this stuff is going to happen. And folks don't like hearing all that negative stuff all the time, and they want to hear something more positive, and we don't seem to be delivering those messages as much. So when you look at solutions, and this is particularly research around black men who have sex with men and HIV, but it can apply to everybody, I can see from here. Peer navigation, having someone who is in the community who is perhaps living with HIV help someone who's newly diagnosed navigate the system. Patient reminders, rapid test and treat options. That's encouraging to a lot of people. Have someone come in on the day they find out they're positive. If they are interested in starting medications, having a link where they can start medications on that day. And so that's very important. And not everybody is going to want that. I work in a student health center, and I've had some students turn up positive, and some of them are like, Doc, I need to process this for a little bit. I can't start right now. And so I always give them the option. I'll say, hey, we have options. Do you want to take it now, or do you need to process, talk to some people? Do you want to come and see me one more time? And this, that, and the other. And some students will choose to take it immediately. What do I need to do? Other students will be like, okay, let me process this. Let me go home. Let me talk to my mother first. All these other things can happen. So I think there's not one right answer. There's only the right answer for who your patient is at that time and what they may want. Case management, interventions, housing, food, employment, education, general health initiatives, not starting with HIV, but miraculously just saying, like, how are you doing? Let's talk about your general health, not looking at a black gay man and saying, like, well, you're black and you're gay. You know you got a 1 in 2 chance for HIV. People get turned off immediately about that. Find out what I'm doing. Find out my other health problems. Find out these other things. And then weave the HIV conversation in there. Getting rid of anti-LGBT and HIV criminalization policies like we talked before. And then homegrown community interventions. The one thing I'll say about this in Atlanta, there are a lot of black gay men in Atlanta. And especially the younger groups, anyone between 18 and 29, if they run in contact with a provider system or a clinic that doesn't do something for them, they'll run out and create something themselves. And there were some brothers in Atlanta, 3 young men, who were all living with HIV and didn't like what they were getting as far as like viral suppression, support, encouragement. And they started a group called Thrive SS, which is an online community support system for black gay men living with HIV. And they have a Facebook page, an Instagram page. I think they have Snapchat, but I don't pay attention to Snapchat. I'm too old for that. And so I look at the Facebook page, and what's nice about it, they started in 2014, and they had about, I want to say 75 members. Now they have over 3,000 across the United States. And so someone who comes in the group who's newly diagnosed can post and say, hey, I'm newly diagnosed. Where should I go to seek care? What are the best places? I don't have insurance, or I have insurance. People chime in like any chat you would do on social media, any post you would put on social media. Some of them will actually post, if they're on medication, their viral loads. They'll take a picture of, my viral load is less than 20. And everyone will be like, congratulations, great job, keep up the good work. Other people will say, hey, my doctor wants to change me from Genvoya to Biktarvy, or another medication. What should I do? What have y'all heard? And people will chime in. People direct message each other. Some people probably will have dates with each other on it at some point. But they get a lot of good information, and it's affirming. So when I talk about homegrown community interventions, it didn't start with a university. It didn't start with a CDC grant. It didn't start with the NIH. It started from the men themselves saying, we need to do something about this. So I think as academics, as physicians, public health officials, other health workers that are in the field, we need to actually pay attention to some of these homegrown interventions to make sure we're not saying, well, we have this great idea, let's get your buy-in on it, but rather, what are your ideas and how can we help facilitate that for your overall health? So it brings me to the last part of my talk, and I'll be done pretty soon, so I hope to leave some time for questions. Have we done a thorough enough evaluation of ourselves as providers? I put these 2 graphs up here. One is by David Che, who used to be with Emory. Now he's with Auburn University. And he actually did a study looking at analyzing geographically across the United States who Googles the N-word the most as kind of a proxy of, and not N-I-G-G-A as in a slang term, but N-I-G-G-E-R. And they found that, a lot of these red spaces and beige spaces were where people were Googling this word a lot more. It's not scientific in the fact that there's going to be like a direct correlation with how racist somebody is compared to how much they're Googling this. But you can see kind of these things, and over on the West Coast, really people aren't doing it that much, but in the darker areas it was. What's more interesting is this is a Harvard test called the implicit association test. Have y'all heard of this? It's it assesses your implicit bias, and it does things between race, gender, discrimination against obesity. And what they do is it's visually. You'll get 2 pictures, and you do word associations: bad, good, uninformed, informed, responsible, irresponsible. And they check to see what you associate, what picture. It could be a black person and a white person. It could be a thin person and a fat person. Either one of those things, you decide what you're going to do, and they time it as well. So they want to see how long it takes for you to kind of make an association between a negative word or a positive word and one of the 2 choices you have. And then they analyze whether you have some kind of implicit bias for or against a certain group. Does that make sense? And so what they found with here was that these were the mean implicit bias scores of white participants that demonstrated a kind of an anti-blackness or a negative perception of blackness. And again, what did we see with a lot of the stuff earlier? So we see these kind of darker areas that steered more towards an anti-black sentiment in the Southeast, which wasn't surprising. When we look at pre-exposure prophylaxis, not just treatment, these are the studies we usually get. When we say, why aren't black gay men taking PrEP? These are some of the things. They have lower rates of knowledge, fewer testing practices, higher rates of transactional sex. That's the typical study we get. Why is the person not doing this? This interesting study below actually looked at med students' PrEP assumptions, and they had them interview patients, black and white, and then whether they would prescribe them PrEP or not. The black patients rated would be more likely than the white patients to engage in condomless sex if they prescribed a PrEP, and then also the med students expressed reduced willingness to prescribe PrEP to the black patients compared to the white patients. So when we talk about pre-exposure prophylaxis and we see the high rates among the black gay community, people say, well, why aren't the black gay community, why aren't they taking PrEP more? It must be that they don't have the education. They don't want to take it. They don't trust it. Part of it may be because of our implicit bias, we aren't offering it more. Or we're making assumptions that they're going to have sex without condoms more, so therefore we're not doing it more. It's a hard pill to swallow that we have to look at ourselves as medical communities and do this, but it may be something that's involved. I know you guys have missed Gordon Ramsay since I showed him at the beginning of the presentation, so I'm just bringing back, and he's screaming at somebody here, obviously. So Gordon Ramsay goes on these TV shows, Hell's Kitchen. He tests people, he screams them, he traumatizes them, they go to therapy afterwards, or they become better cooks, who knows what they do. But then that's in Hell's Kitchen. When he does, what's the other one we talked about? Kitchen Nightmares, yeah. I was thinking about the other one. So Kitchen Nightmares, you go into a failing restaurant. So you look at a restaurant that, customers aren't coming back. They aren't seeing anybody. And so they're starting to notice that business is out, and it's hurting their bottom line. And he comes in and kind of finds out from top to bottom what's happening in this restaurant. So I presented this at the International AIDS Conference in Amsterdam when I did a plenary speech. And one of the things that I thought about when I thought about Gordon Ramsay was like, medicine is a business now, right? It's very much a business. It's driven by RVUs. It's driven by how many patients you see. You get pressure to see people in 10 to 15 minutes, outcomes, so on and so forth. But we don't do enough about customer service. And if you put the analogy of a restaurant business with kind of an HIV clinic, or any other clinic, I would say for that matter, if you had patients coming in for a first-time visit, right, and the analogy would be in a restaurant, they came in to eat a meal for a first time. So someone comes in to see you for a first time, and then they don't come back as a provider. What is your initial response? Or what would your initial research question be? Why didn't they come back? Would you point the why to what's wrong with them that they didn't come back? What would you ask? What questions would you ask? So you would ask questions like, does our food suck? Is it awful? Is it seasoned enough? Are our staff helpful? Are they courteous? Do they treat customers with respect? Is it geographically located in a place that's easy to get to? And do we provide them good customer service? And what we see in the medical profession in this HIV treatment cascade is the exact opposite. Instead of looking at ourselves, what we start to do is just say, well, what's wrong with them? Oh, the HIV stigma in the black community. Oh, it's this, that, and the, oh, the homophobia in the black community must be what's causing it, so these people don't want to come in. Oh, they're uncomfortable, they're on the down low. Oh, there's a denial about HIV, they don't trust. So it's all focused on them, where the fact of the matter is there could be something that we're doing that doesn't allow somebody to come back or doesn't make someone want to come back to visit us. The same way you wouldn't go, if you had a nasty meal at a restaurant, would you go back? Or if you were treated poorly by the server or by the manager, would you go back? You wouldn't go back. You'd probably go on Yelp, give them a bad review, and then you'd come and you just slam them. But we expect patients to keep coming back, even though they are treated with disrespect sometimes. They have to wait long periods of time, and people don't see them. And so when I look at someone like Gordon Ramsay or Robert Irvine, Restaurant Impossible, it's almost like we need somebody to come into these clinical spaces and analyze everything from the moment you walk in the door to when you exit and see why people are or are not coming back and go from there. And I think Restaurant Impossible or Kitchen Nightmares may be a better analogy than Hell's Kitchen. So when we look at the medical context, we look at things like implicit bias among providers and staff. We look at inefficient institutional process. And for instance, at Ryan White clinics, when someone has to sign up for ADAP, the AIDS Drug Assistance Program, they have to renew every 6 months. And so they have to fill out all this crazy paperwork to get their HIV medications for free. Now, if you think that patients are coming in between every 3 and 4 months, that's between like 2 visits that you're actually going to have to come back and renew all that paperwork, or you can't get your medications. Is that a fire alarm?
Rapid response team.
Oh.
Main hospital. Basement level 2. D. Delta wing.
Okay. All right, good.
Physical therapy. Rapid response team.
Does that happen a lot? Okay.
Basement level 2. D. Delta wing.
Anyone got to run out? Or okay, y'all are good.
Rapid response team. Main hospital. Basement level 2. D. Delta wing. Physical therapy.
Wait, one more time? No, I'm sorry. So inefficient institutional processes. So how can we improve the paperwork, the time spent that clinicians have to come in or patients have to come in and do this stuff? What do we need to do? And then thinking about words matter. Sometimes we don't think about what we say has an impact on patients, but we still in 2018 use the phrase compliance. You're non-compliant, which immediately sets up a power dynamic. We still use terms like HIV infected. I went to a conference in Florida with a white woman who was an IV drug user and had been HIV positive for 30 years. And she said, when people call me HIV infected, it makes me cringe because I don't want to think of myself as infected for 30 years. And she had a very good point with that. So using terms like HIV positive or living with HIV actually sends a message to someone that they're not like some kind of disease that we have to stay off of. And we're the biggest perpetuators of that. And then also retained in care. Retained a lot of times means you're holding somebody there, like almost like a correctional facility. I'd rather use the term engaged, especially when we're looking at racial disparities. It's not smart to use the term retained and kind of refer to correctional facilities. And then I use the term geeking out, and I put Revenge of the Nerds, because that was one of my favorite movies in the past. But like geeking out, I think we're all nerds. Can I say that safely? Like in medical and public, like we're pretty much nerds. We geek out over different things. But I think what we're doing right now, we get so caught up in the science, and we have some exciting science with single tablet regimens. We're soon probably going to get to a point where we have 2 medications in one pill being one standard that we can do. We have broad neutralizing antibodies, vaccines, long-acting injectable versions of PrEP, vaginal rings we can use. And we get so excited about that, we forget about the human beings that are actually going to have to take this. So we forget about the human part of HIV because we get so geeked out. Like, we have this great science. Why aren't you coming to take it? And it's easy to pathologize the patients instead of saying, like, well, what's going on? We have this science. There's got to be something that we're not doing right to actually get this to you. So if we can flip the emphasis instead of pathologizing communities for not coming to see us, as to what we are doing better, it may be a better outcome. And then lack of perceived experience medical support. There was a study, the Positive Perspective study, that showed that whether people were HIV negative or positive, they felt like they weren't getting support either from their community or from medical facilities. So we can't control what happens in the community when they leave our offices, but we can control how safe they feel in our spaces. And then finally, representation is not reflective of patients. So in a lot of these studies that we see in a lot of these clinics, it's predominantly black patients and minimal black providers. And so for the long term, we really need to work on getting more black, more Latin, more Asian, more diverse people of color in these facilities who are actually doing the work. And this was from a study that was presented earlier this year that talked about when black men actually went to black male patients as opposed to white or Asian male patients, they were more likely to receive preventive services. Like, it was statistically significant, like 30 to 40% more likely to receive messages about colonoscopies, routine screenings that they had to do, vaccination, those kind of things. What we do need more information on is process evaluation in medical settings, patient-provider interactions, staff-patient interactions, medical environment assessment and options, and also investigations being as specific as the epidemiology suggests. So if you keep saying that black gay men are the epicenter of the HIV epidemic right now in Wisconsin, Milwaukee, Madison, and across the United States, why do you dilute it down to just people of color when you come up with solutions? It's really easy to be specific when pathologizing a group, but it seems to be harder for us to actually be specific and say, well, what do you guys need that's specific to black gay men when we're doing these solutions? And we have to do better for that, because these contexts actually influence how people navigate through the cascade. If they don't trust us or they don't think that we have the best interests at heart, they're not going to come to see us. So in summary, the HIV epidemic is squarely based in the South and among Black and Latinx folks. New infections are happening and poor virologic outcomes. There are historical and current contexts that create and reinforce these inequities. Medical settings, processes, personnel are all part of these contexts. So it's not acceptable to just say, well, social determinants and not include medical spaces as part of those determinants in this day and age. Future directions and solutions, I say to be determined or to be discussed. I don't know the answers because we don't have it figured out in Atlanta, where the CDC is. We don't have it figured out. We have some of the highest rates in the country. It's going to be clinic-specific, geographic specific, zip code specific, population specific. So we have to find the answers in here. So the challenge to you guys here in Madison is to find out what's going on here and what do these specific clinics need to be working better so we can improve solutions for our patients. And then it's up for us to improve our context, not to force our patients to adapt or tolerate us. And then do we actually need a reality medical TV show? Like, do we need Dr. Sussman to kind of go around and like with a sledgehammer and like knock down medical buildings and interrogate all the staff and traumatize them to do better? We may need that at some point, so that could be an option. And then I want to leave you with this. Science is wasted if we forget about the art of medicine. And I'm going to use a quote. I did a qualitative study years ago that I published, and we interviewed black gay men in New York City and upstate New York about their experiences with medical providers. And this gentleman was a 60-year-old man with hypertension, diabetes, and congestive heart failure, kind of the typical stuff you're going to see in your general medicine clinic. And we asked him why he didn't why he didn't follow up with doctors. And here's what he said: "Make me feel that it's a positive enough process that I will work towards doing my part in it. Because if I've been turned off, then I don't want to hear anything. And I will probably act in a manner that's not in my own self-interest because I've been turned off by the whole experience. Whereas, if I feel like someone else cares, that's kind of encouragement for me to really invest in myself better." So while we're sitting around waiting for the patients to just pull themselves up by their bootstraps, a lot of patients may be waiting for us to actually show that they're cared about, because people are dealing with trauma and people not valuing them in their lives, and they're looking to us to give them that reaffirmation so they can take care of themselves. So if we just flip the emphasis from them to what we could be doing better, we may see some better outcomes. That's all I have. I thank you guys very much.
So what a timely and important talk with so many synergies for healthcare reform and system redesign, which we're working on as well. So questions from the audience?
No? Yes?
As a clinical researcher, I think it's really interesting in the ECHO study that my assumption is that the providers have the consent to being reported and understood that, and if they perform that poorly, knowing somebody who's going to be listening to the transcription, it blows my mind that how really poorly they do.
Yeah, I was going to say it's almost like you could look at it as a selection bias, because the ones that actually agreed to it probably knew they were on being audio recorded, so they amped up their stuff. So it's probably only the tip of the iceberg of how bad it could be. Right. Yes.
You haven't mentioned either incarcerated patients or reentry patients. Can you say about those?
Yeah, I think... Oh, I'm sorry about that. The question was about incarcerated patients or reentry patients, and that's a great question. And I think as someone who's worked in a couple of jails within the past 5 years, I can tell you that not only on the HIV testing front, where they're not doing routine testing where people come in, particularly in the jails because it's such a quick turnaround. Someone goes in, they don't even know if they're going to stay there overnight. And then getting pushback from the staff, knowing that they can't do it. Whatever problems we see in general medical context, you can amplify those, put them on steroids by 100%, and they're a lot worse in these correctional facilities. And then, again, like you said, when we're sending people out, there need to be more kind of orchestrated plans, especially for the patients living with HIV, to say, okay, we have a case manager that's here, someone who's living with HIV, if they're either starting medication or maintained on medication, they have a direct link to the clinic afterwards. Sometimes that's missing, sometimes that isn't present at all, sometimes people just fall through the cracks, but it's a huge problem in everywhere, and particularly the South. I imagine it's probably an issue here as well. But the solutions would be, it has to be coordinated between the medical facilities, the hospitals, the jail, and the clinics, as well as social workers or case management. And what I found in correctional facilities is that the message I got after working in a couple of them was that the main emphasis is security. Everything else is secondary, including the health of the patients. And I've been told that very time. Some of the phrases they used to give me in Cobb County Correctional Center, they used to call me Robin Hood and do-gooder, because I wanted a baseline level of care for the inmates, and they felt I was going above and beyond and giving them boutique care. So when you're fighting against a system that actually thinks that the people that are coming through don't deserve any health care at all, they just need to be locked up, it becomes problematic. But that's a great question. Yes?
That was really a great talk. Thank you very much. I just want to give a comment. I used to work it was a standalone HIV and infectious disease, and it clearly says that. So the single most complaint that we have to get was that the name really
Yep.
affected them from not having them.
Yep.
So one of the things that I never did is standalone clinics are the worst thing that you can do. The fact that we are mixing here, I really like it. It just doesn't discriminate, just even by building, whether you have those or
Yeah, and that's a great point. And even in like rural settings, like North. Repeating the question.
Just repeat like the standalone versus.
Yeah, we're talking about whether a standalone HIV clinic may actually have some stigma to it, in addition, or whether we have something that's more integrated into a healthcare system. And I do think the integration model is so much better because even in Atlanta, I used to work at a county clinic that had 4 floors. All of its work is devoted to HIV, from research to clinical practice to mental health, everything. And it didn't have the name, HIV clinic or sex clinic or anything like that, but people knew that big white building near the Krispy Kreme in Midtown Atlanta. That's where you go if you're this. And people get afraid because if they walk in there, that they're going to be, even if they're going to visit somebody, they're not HIV positive. If somebody sees them from the community and says, what were you doing in there? So it was problematic. And then there were people trying to make it so that we could have a PrEP clinic there. And I was thinking to myself, how are you going to get HIV negative people to go in a clinic that's geared for HIV, folks living with HIV, and not have them feel that kind of stigma or pressure? Of course they're not going to come to that. So it's a great thing. I work in student health, which I love to do because when people come in student health, whether they're positive or negative, they're just getting tested, they want counseling, they just come in and they just go into the doctor's room and nobody knows why they're there. And so that's always been kind of a pleasure. But I think having those kind of models where it's more integrated, as well as more unique models, and almost like to keep with the restaurant analogy, like a menu of services when someone comes in. Like, what do you need? Are you comfortable with coming into our space? Or do we have a team that we can send out, like a social worker, a nurse, and a provider that we can send out to see you if you're having trouble with transportation? Let the patient kind of drive what option they may need at a certain time and be flexible enough within our clinical practice that if their conditions change, they lose their insurance, they lose their transportation, they have to move, and it becomes more difficult, that we can actually modify what we do as a medical community to meet their needs and make sure that they get reassigned for their AIDS drug assistance program, get their social work paperwork together, get their medications lined up, all that kind of stuff. So I think there's a lot of stuff that we can do, but the first thing that you did that proves the point that I'm saying is that you asked the patients. And so a lot of times we'll say, well, we did a survey, and the survey is like, how great was your experience from 1 to 5? I'm a qualitative researcher, so I always recommend getting people in a room, giving folks some food or a small cash incentive like $25 or $50 and saying, tell us what's going on. Because folks will give you the answers if you ask. And those answers and the depth of those answers will not come from a simple multiple choice survey question. So that's a great point.
So I think we're going to close here. Other questions, please come on up to the front, and thank you.
All right, thank you guys so much. Thank you.